Hello everyone, welcome to my channel. In this video, we're going to focus on iron deficiency anemia. In the last video, we talked about anemia in general, what to do when hemoglobin is low, and how to classify a patient according to their MCV. So please make sure to check the video to understand better. To recap, anemia is defined as low hemoglobin levels lower than 13 gram per deciliters in male, 12.5 in females, and 10.5 during pregnancy. Iron deficiency is the most common cause of anemia in the world. It happens when there is a lack of iron in the body. Quick recap on iron. Iron is a key component of hemoglobin, as 70% of iron is found there, which explains why anemia is the most frequent manifestation of iron deficiency. Its roles include transporting oxygen from the lungs to the tissues and removing carbon dioxide. It's also found in myoglobin as it stores oxygen in the muscles and gives the muscle its red color. It's a key component in enzymes as it's vital for energy. It's also vital for the functioning of the immune system. Next, we're going to talk about the physiology of iron. 1 till 2 milligram of iron is absorbed daily in the duodenum and the upper part of the jejunum. Then it's transported through transferrin to various tissues, especially the liver, where it's stored, and the bone marrow for red blood cell production. Iron is stored in ferritin, a protein that's found in most tissues, especially the liver, the spleen, the muscles, and the bone marrow. If there is a severe overload of iron, it's stocked in hemosiderin. Iron is regulated with hepcidin, which is secreted by the liver. It inhibits iron absorption. When there are low levels of iron, hepcidin secretion is then reduced to promote iron absorption. 1 till 2 milligrams of iron is excreted, the same amount as absorption, slightly more in women through desquamation, urine, sweat, and menstruation. We're now going to briefly talk about the pathophysiology. The most frequent mechanism is chronic blood loss. We also have low intake. Iron comes from food. It's only logical that an inadequate diet would lead to anemia. Iron is found in two forms, either heme in meats, fish, and poultry. This type of iron is easily absorbed. On the other hand, the other form, non-heme, which is found in plants, is not easily absorbed. It's also important to know that there are drugs that decrease iron absorption, such as proton pump inhibitors. On the other hand, ascorbic acid and citrates increase the absorption of non-heme iron. A healthy diet consists of 5 till 15 milligram of elemental iron, 1 till 5 milligram of heme iron. Only 1 till 2 milligram is absorbed. Low intake then leads to iron deficiency. We also have decreased intestinal absorption in the GI tract, mainly the duodenum and the upper jejunum. An increased demand, an increase in the need of iron, for example, in multiple pregnancies and adolescents. Low iron leads to low hemoglobin since it's a key component. The red blood cell in this type of anemia will appear smaller with a low number, which explains why we find a microcytic anemia in the full blood count. Microcytic means it's smaller in size, since the MCV reflects the size. It will also appear paler since iron gives the red blood cell its red color as it carries oxygen, meaning we'll have hypochromic anemia as well. Low MCHC as it indicates low hemoglobin. And it will be non-regenerative. Low iron, the bone marrow won't be able to produce red blood cells efficiently. Now, we're gonna talk about the diagnosis of anemia, starting with symptoms. General symptoms of anemia include pale skin, shortness of breath, rapid heartbeat as the heart tries to pump more blood, fatigue and dizziness. Now, for specific symptoms of iron deficiency, we talked in the physiology of iron about its importance in enzymes and the immune system. It's especially important for epithelial cells health as it's a key component of their enzymes. So, the symptoms revolve mainly around the mouth and oral tissues. We're gonna have angular colitis. It's an irritated red cracked sores or fissures in one or both corners of the mouth, and glossitis, especially the atrophic form from the lack of oxygen. In terms of skin and nails, we'll have dry skin and dry hair as nutrients are essential for maintaining skin and scalp barrier. And koilonychia, meaning concave spoon-shaped nails from insufficient oxygen. There's also a very rare condition that can happen in extreme cases called Pica syndrome. The patient eats non edible things such as hair, earth, ice, and the cause in unclear. The most widely accepted is the compensation of nutrients lacking, especially iron, zinc, and calcium. For biological findings, if you understood the physiology and the pathophysiology, you'll figure this out on your own. So, it's hypochromic, microcytic, non-regenerative anemia. Anemia is confirmed with low hemoglobin levels. Now, for iron deficiency, you're gonna find in the full blood count low MCV, since we said the red blood cell will be small in size, low MCHC, since they'll be paler, and non regenerative, meaning we'll have low reticulocyte count. For iron panel, serum iron will obviously be low. Ferritin will also be low. Low iron means low stores. The total iron binding capacity will be high. Now, why is that? The liver will release more transferrin to absorb any iron, but there will be no iron to bind to, so the capacity to bind will be high, which also explains why the transferrin saturation T set will be low since we'll have more seeds and no iron available. Now, you diagnosed anemia, you have to know the cause. Since we said anemia is a symptom, so you need to figure out what's causing this iron deficiency. The most common causes are blood loss ones, starting with digestive ones, which are the most common in males. And we're going to start with esophagus causes, like, for example, esophagitis. It can even be due to GERD or treatment such as PPI, tumors, or esophageal varices. They are enlarged veins that we find most often in portal hypertension. Now, moving on to gastroduodenal causes, we can have gastrectomy, tumors, or ulcers. All of these causes can lead to bleeding. Intestines, we have tumors or diverticulitis. It's an inflammation of the diverticula. It's an irregular bulging pouches in the large intestines. Angiodysplasia, they are abnormal tortuous blood vessels or chronic hemorrhoids. Moving on to gyneco-obstetrical causes, we have pregnancy, cancer, endometriosis from heavy menstrual bleeding, or uterine fibroid. Other causes can include chronic epistaxis, frequent blood tests and donations, or a syndrome called Lastini-Duferjol syndrome. It's self-induced blood loss. It's a psychiatric disorder. We can have low intake, for example, malnutrition, especially in elderly, or strict vegetarian diets. Hence why it is advised to increase vitamin C to facilitate the absorption of non-heme iron. Causes of decreased absorption, we have resection of the duodenum and the upper jejunum, inflammatory bowel disease through damage in the intestine lining, celiac disease, and heavy tea consumption, as tannins found in the tea inhibit the absorption of non-heme food. An increase in the demand, especially in adolescents and in multiple pregnancies. For investigations, if it's a woman of childbearing age, you need to do a full gynecological examination from vaginal ultrasound to cervical smear. If it's men, older women, or kids, you need to do gastroenterological exam. You can go from OGD to coloscopy and even biopsy. Now that you understood the pathophysiology of iron deficiency, symptoms of anemia, what to find in blood tests, the causes, and how to investigate, we're going to finally get into the management. For management, we can have oral iron in the form of ferrous sulfate 100 milligram per day. It can have some side effects, especially on the GI tract, so make sure to warn your patient about them, as the patient can have symptoms such as nausea, vomiting, diarrhea, or even constipation. Intravenous iron, it bypasses the GI tract. It's especially indicated in malabsorption, in IBD, malignancy. It has less side effects and rapid correction. Red blood cell transfusions if you have severe anemia, meaning hemoglobin of lower than 7 gram per deciliter. Treatment should be maintained for 4 to 6 months. You're going to have reticulocyte crisis after 10 days, as the bone marrow is going to respond quickly, so you'll have an increase in erythropoiesis. Hemoglobin will rise and become normal within 6 till 8 weeks. Then you'll have a correction of the MCHC, the MCV, in around 120 days. Then transferrin, and finally ferritin. So, the clinical correction of hemoglobin and the symptoms will happen in around 2 months, and the replenishment of iron stores will happen around 4 to 6 months. Thank you for watching the video.